Good evening, everyone. I'm not gonna Ryan it and gavel it. Nobody's rowdy today, so I don't need to gavel. I would like to call to order the February 23rd, 2022 CMH full board meeting, and we will start with the Pledge of Allegiance. Please rise. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Oh, I didn't pick anybody to read the mission statement. So, Ryan, would you like to read the mission statement?
Our mission, Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence.
Thank you. Next item is adoption of the agenda. I'll take a motion to adopt.
So moved. Support.
Motion from Megan, support from Lori. Questions, comments on the agenda? All in favor signify by saying aye.
Aye.
Aye. All opposed? The agenda is adopted. Next is item 4, hearing of the public. Anybody from the public wishing to speak? You have 5 minutes. Not a lot of public. We will close the first hearing of the public. There will be another one before the end of the meeting. We'll move on to item 5A, approval of the minutes of the CMH full board meeting on January 26, 2022. I'll take a motion to approve.
So moved. Support.
Motion from Linda, support from Donna. Questions, comments on the minutes? All right, hearing and seeing none, all in favor signify by saying aye.
Aye.
Aye. All opposed? Minutes are adopted. Next is item 6A, approval of the minutes of the CMH Program and Budget Committee meeting on February 9th, 2022. Motion to adopt.
So moved. Support.
Motion from Ryan. I think I heard Antoinette. Yeah, perfect. Questions, comments on the minutes? All right, hearing and seeing none, all in favor signify by saying aye.
Aye.
Aye. All opposed? Nick, did you have a question?
No, go ahead.
Okay, minutes are approved. Next is item 7, request to approve. Nick.
I move to approve items 7A through J.
So support.
Items A through J, motion from Nick, support from Megan. Are there any questions or comments on any of those items that we covered at program and budget? All right, all in favor signify by saying aye.
Aye.
Aye. All opposed? Those items are approved. Next is a new item, item K, request to approve the Citizens Advisory Council candidates for appointment. Take a motion to approve.
Motion to approve. Support.
Motion from Lori, support from Donna. Do you want to come up and speak, or you want to? Dave says yes, you do, so I guess you have to.
Yes, I do, Dave.
Is it on? There you go.
Now you're good.
Look at that. My name is Anwar Gulati. I am the Ombudsman for Community Mental Health, but also newly appointed as CAC Liaison. And tonight, I'm excited to recommend 3 candidates for the Citizens Advisory Council. First one is Jesse Court from Chesterfield. Jesse has a social work degree and has a history or experience as a case manager since 2002 and specializes in areas of leadership management, homelessness, housing, substance abuse, mental health, medical and primary care. And currently she is a care coordinator at Mccarron. She's an advocate for the community members, or she wants to advocate for the community members that are affected by services through the community mental health by providing feedback to the CAC group. She would be one of our community representatives. The second person that we'd like to recommend is Donessa Crivella. She is a parent of a child through our Children's Waiver Program. Her hope is to bring experience and insights as a parent of a child who receives Macomb County Community Mental Health services to the CAC group. She has 20 years of experience as a parent and professional in the field of education, administration, and advocacy. The last person we're going to recommend is Mae Dixon. Eddie Mae is a proud mother of 2 adult children who receives community mental health services. She also receives community mental health services through us as well. She has a history of being in a few council committees through Disability Council, Michigan Rehab Council, and Community Relations Council. She wants to offer not only her personal experience, but also perspective as being a parent regarding mental health services, advocacy, and community participation. So currently we have 5 members in the CAC Advisory Council. This would put us at 8, 6 of which would be primary and secondary representatives, and 2 of which would be community representatives. And I'm excited for all of them. They're all good candidates.
Thanks, Anwar. Any questions before he runs away?
I have a comment.
Linda, go ahead.
Anwar is the new liaison to the CAC, replacing Lori Valuet. And Lori Valuet and Anwar have been working for a long time to build up the quality and the attendance at the CAC. And, you know, when I go to conferences or talk to Malkia, who runs the Person Served Conference committee, they a lot of counties do not have the kind of CAC that we have, where such good representation, attendance, and being able to give us the feedback that we need from the people who are served. Dave comes to every meeting and he talks and talks and talks, and then he gives them such good information. But then they're able to give him their feedback and say what their concerns and their issues are. So thank you for finding these quality candidates and bringing them to us.
You're welcome.
Thanks, Linda. Donna?
Yeah, I read the biographies of the 3 candidates you're presenting to us tonight, and I was really impressed. So thank you very much for bringing such qualified candidates to the board tonight. Really appreciate it.
And if
Thank you.
anyone in the board has any candidates they would like to nominate or have me look at, we're always willing and open to take in more candidates. So thank you.
Thanks, Donna. Anyone else? All right. Thanks, Anwar.
Thank you.
We have a motion and support to approve these candidates. All in favor signify by saying aye. Aye. All opposed? They are appointed. Next is item L, which is also a new item. A request to approve a rate increase of 8.62% for all other services beginning March of 2022. Take a motion to approve.
Move to approve.
Support.
Motion from Linda, support from Ryan. Take it away.
I will be abstaining.
Thanks, Lori. Dave, go ahead.
Well, first, thank you to the board for entertaining this. I mentioned it at the program and budget, and we did supply the detail, which was a rather lengthy spreadsheet. What we did is we backed out the hospital providers, the specialized residential providers, and what you have from that spreadsheet is the rest of those service codes, with the caveat that we will still be considering, we're looking at the rates we're paying for the psychiatric services, the medication reviews, and the psychiatric assessments. But what that equates to is an annualized increase of a little over 7.2 million for the remainder of this fiscal year. It would be 4.2. And I'm looking at the summary. I'm not sure if that's calendar year or fiscal year, but so that does, we do not have a standard fee schedule, which would make modifying rates a little bit easier across the board. So our best guess was to do it through this across the board rate increase. It does, as I indicated, the language will be tied to 6 months after the ending of the federal state of emergency that we're currently under. So if that ends, they would start disenrolling our Medicaid. People that were no longer eligible, our capitation revenue would decrease, but we would be able to weather that we expect those decreases to hit about 6 months after the ending of the state of emergency as well. Again, it's part of my comments later, but our providers are struggling, that the staff shortages are critical. We are trying to do as much as possible to assist them, and this is definitely a step in the right direction.
Nick?
Dave, I think with the materials you've given us with your oral representation, we kind of got the idea of what all others means, but in the motion and in the agenda, it's not that clear. Could you attach to the minutes the list of actual rates that are impacted by this, as opposed to saying all others except, just which ones are included, so that the public, when they review if they review the minutes, will know what all other means?
Yeah, we could do that in categories. So yeah, it would be.
I just asked that be included
in
the minutes. I mean, you've explained it to us
I'll
orally.
work with Sandy to make sure that the categories, the general categories, are included in the minutes for what we mean by non-residential, non-hospital.
What all other means.
All other, yeah. Yep.
Thanks, Nick. Any other questions, comments, suggestions? Okay, all in favor signify by saying aye.
Aye.
Aye. All opposed? Motion passes with Lori abstaining. Next is item 8, receive and file. We have no items there. We'll move on to number 9, resolutions. We have one for Stephen Smith. Take a motion to approve his resolution.
So moved. Support.
Motion from Linda, support from Lori. Questions, comments? All in favor signify by saying aye.
Aye.
Aye. All opposed? Motion passes. Next is the voucher listings, list of bills for 1/15/22 through 2/11/22. Take a motion to pay the bills.
So moved. Support.
Motion from Megan, support from Linda. Questions, comments about the bills? All in favor signify by saying aye.
Aye.
Aye. All opposed? Bills are paid. Now we'll move on to the management report. We'll start with Richard with the CFO update. I know traffic was abysmal out there.
Yes, there was there was an accident, but luckily I was not in it.
Good.
Well, it is nice to be back. It's been a few months, so it's been a crazy few months. So, December 2021 finance reports. I would like to just mention that this is the first report out of our new general ledger system that did go live in October. I'll be the first to admit, and I think others that have experienced this, any kind of technology transition has its bumps and bruises. So I'm actually pretty happy with where we're at as of today and where we're moving forward to. So just a quick update on that for you guys. A couple of highlights for the December financials. On page 1, looking at our revenue trend, you'll notice that our revenue for October, November, and December is about even to where it was last year. There was a little spike last year, and just a reminder, those two little spikes that you see in November and February was when the state paid our DCW. They kind of lumped it all into those months, and so that's why those two spikes existed. We've leveled off pretty much for October through December. We are anticipating a revenue increase in April. So as you may recall, the budget that was approved back in September did call for the DCW to be paid out at $2.35 per hour. Because the rates are set prior to the beginning of the fiscal year, because MDHHS has to send that out to CMS to approve in advance, they weren't sure what was going to actually get approved in the final budget. So what we get paid for the first 6 months is actually based on the original estimate by the state that they were going to approve $2. So that 35 cents isn't built into the revenue that we're receiving yet. Starting in April, though, we will see that revenue increase to cover that. We are paying the $2.35 now, even though the revenue is not coming in, because we do have sufficient cash flow to make that happen. Highlight on the second graph on that page for the eligibles. Our eligibles continue to stay higher than prior year. Again, this is tied to the federal emergency. And again, we do anticipate at this point that it will last at least through September 30 at this point. And there's the potential that it's going to be extended another 30 days. So it may last through the end of the calendar year. So we'll keep our eyes on that because, as Dave mentioned in the previous discussion, when that does end, then our Medicaid eligibles will reduce and we'll have to be paying attention to our revenue reductions. Moving on to page 2, just a couple of highlights. Cash and investments through December are up from September about $20 million. This is almost 100% a result of again, more revenue coming in than we have expenses at this point in time, and again, more revenue because of more eligibles in the system. No other specific highlights on the balance sheet on page 2. And if we look at page 3 on our income statement, at this point we are anticipating our revenue, our capitation revenue, is going to be slightly higher in 2022 than it was in 2021. I will just quickly caveat, we're finalizing the final financial reports for 2021. They're due to the state at the end of this month. So these numbers are still subject to change a little bit. And we would, of course, update those in a future finance report for the board. So if we move on to page 4, just a quick summary by fund source of kind of where we're at through December. Our Medicaid, for our Medicaid, we're showing a surplus of almost $12.5 million through December. Autism, another surplus of about $2 million. That's a combined surplus in the Medicaid category of just over $14.5 million. Healthy Michigan is also showing a surplus, $3.6 million. And then in our state general fund through December, a surplus of about $400,000. So at this point in time, if we are planning on fully funded ISF, fully funded savings coming into fiscal year 22. So all other things, if December was the end of our year, there would be just about $18 million that we'd be sending back to the state. So that's kind of where we're at through December. Any questions or concerns on the finance report?
Donna?
Yeah, I noticed on page 2, on the employee payables, that it was a bit higher. I'm just wondering, that kind of intrigued me.
Let me take a look. So employee-related payables are up.
It's on the liabilities.
Mm-hmm. So
It seemed a bit high, and I was just wondering, was that due maybe to that wouldn't be the approved rate increase that we had?
It could be related to that. Let me dig into the details for you on that one and bring back some explanation on that. It could be related to how we book the retirement contributions that we make for the pension and possibly the OPEB. So I want to verify that before I give a final answer.
Yeah,
Yep.
that kind of intrigued me, so I was just wondering why that would have gone up.
Yep, understood.
Okay. Thank you.
Thanks, Donna. Anyone else? Okay. Thank you, Richard.
Thank you.
Next, we'll move on to the CEO update from Dave.
Well, good evening, everybody. First, there was a question on one of the approved items from last time about the lease. When the staffing provider in the lease facility does some of the improvements that may not have been approved ahead of time. I just want to let the board know we did follow up with legal. We do have the capability to recover those funds under those situations, but we would definitely benefit from some improved, clearer language in our contracts. We'll be working on that. Speaking on the legal front, I've mentioned to some of you But Aaron Thomas, who is our primary legal support through the county, his last day is this week, Friday, I believe. Yeah. Like to publicly thank Aaron. He's been a huge help and resource and to us, and he will be greatly missed. So we are working with the county legal about establishing those contacts. You may not realize, but we have a system set up with the Office of the County Exec, where if there's a contract, it goes into, Sandy puts it into a formal tracking system that goes to Aaron first. He reviews the legal language in there, then that goes to program and budget, then to full board, and then back to the county exec for signature, my sign off approval. Then it goes over to the office of the county exec. So it had been working very well, and Aaron has just been all around helpful in a number of, hey, can we do this, or hey, this came up. Our system is a little unique, and that's understatement. Aaron knows our system very well, and like I said, I just can't thank him enough, and he will be greatly missed. Yes.
Is there, excuse me, I saw your email come out about that. Is there like a temporary person that can be assigned in that chain of things and that the county can assign it to while are they looking for a replacement actively and then?
I believe it's
okay.
been posted. So we definitely need to work out some procedural things to make sure the day-to-day stuff continues to go on. So yeah, I'll provide you updates as that becomes clearer.
Thank you.
I touched on it, but really can't thank our providers enough. This pandemic, the waves, the never-ending, the not sure when it's going to end. The staff shortages remain beyond critical. They're impacting our entire system. We do have, unfortunately, people that are struggling. They're being more directly impacted by the staffing shortages than others. We do have people at the hospitals. The hospitals are, definitely struggling on the medical side with their emergency rooms and people with COVID. But the psychiatric hospitals are also having staffing shortages. And then we do have people that present at an emergency room or are ready to be discharged from a psychiatric hospital, and the community supports that they had available to them are no longer available. So I'm meeting with Henry Ford this week. We met with Mccarron. There's no quick fixes, but we're definitely looking at some options. We're meeting with some providers about their transitional beds, which is something Macomb has not had to the best of my knowledge, or definitely not since I've been here. We would be using general fund to pay for an available bed to be available to us in an urgent need. And then when a person went there, if they had Medicaid, we could definitely make it a Medicaid covered service. They're short term. They give us time to get some assessments completed, get some more information about the person, coordinate their possible insurance coverages and available benefits, and then work on finding them someplace else. So it's a missing piece in our continuum, and we're meeting with a provider who might be able to assist in that area. We are also, with Christina and Kathleen's help, we are doing a mailing out to all of the general adult foster care homes. So again, you can be licensed as an adult foster care home in Michigan, and you take people in, they sign a residential care agreement. You basically, it's the majority of whatever income they have available. We cannot use any Medicaid dollars in that type of licensed facility because it is not specialized. It needs to be certified as specialized by the licensing as either MI, that they can have people with mental illness, or IDD, in order for us to use our Medicaid dollars, which are the personal care or community living supports in a licensed setting. So we're going to reach out to those homes, see if they have capacity and an interest in contracting with us, and then we would have to provide a lot of support to teach them what it takes to become specialized, meet all the Medicaid rules and regs. But we're willing to do that right now because of the need is so great in our community. We are also doing another mailing out to all of the homes that are licensed, but they have a specialized cert as TBI. That's traumatic brain injury. If you recall, the auto no fault impacted those homes greatly, those providers. But they have staff. If they have beds and capacity, we think it'd be a good fit. And then they would simply have to become certified for the to help people with mental illness or developmental disabilities. So we're doing that, and we'll be tracking those responses and stuff too. We have a very nice mailing that's going out to explain what we're looking for. So we'll keep you posted on that.
Did we have a presentation? Was it Eisenhower that was a TBI? Okay, I
Yeah.
remember that. Okay,
Yeah.
so it's like a similar type of practice.
Yeah,
You're
there's a whole
familiar.
nother network out there that is licensed, that is certified as TBI. So we're reaching out to that system to see if they have any capacity. Even if it's one bed, we'd be, single case agreements.
Something.
We're willing to, be very flexible. We did get our readiness presentation, the results of the readiness survey from our NCQA consultants, the Mahalik Group, on February the 11th. It was as expected. We have a lot of work to do. Basically, it will be a 2-year plan, policies and procedures, credentialing, utilization management are those key points. So we'll be working internally. Stacy's group, quality and compliance will be key, but we'll be working in a concerted effort to meet all of those standards. And again, we'll keep you all posted on that. I received an email from Alan Bolter just before this meeting, and I printed it off and then left it on my desk. So I have to read it from my phone. This is from Alan Bolter from the association. We have heard that Senator Shirkey intends to bring the Senate Bills 597 and 598 up for vote next week in the Senate. Whether it is next week or the week after, we know the time is approaching for these to come out of the Senate. Please consider reaching out again to your local senators and representatives, primarily senators at this point. If your county passed a resolution in opposition, please remind your senator of that as well. And he included emails that were sent out to the Michigan Senate from the association. I will forward this email to the board. But again, advocacy now is more important than ever. And in an earlier email, they included that link where you can contact your senator easily. They're making that as easy as possible. So that's
Nick?
I
moving
have a
quick.
question on that point.
Nick and then Linda.
Oh, Simon. He sent out another email just prior to that. I don't know if it went to all of the board members dealing with the EPIC MRA poll that was pretty helpful in making arguments. If the other board members didn't get that, I'll forward it around. Did anybody get it?
You sent it to me, I think so, yeah.
I sent it to you?
You forwarded it to me.
No, I didn't send this one yet,
Yeah, you did.
because I just got it today. I may have sent you something similar, but I didn't send this one.
You sent me something. Yeah, you that one.
Send it around, would you, Nick?
Yeah, I'll look for it.
Okay, I didn't want to repeat it. If Alan had sent it to all the board members, I don't know, he may have just sent it to people on some, I don't know what listing would have.
Yeah, I don't have that email.
Yeah, it has some very good information that are useful and that you can use in making your case with the state senators in your travels. So I will send it around to the full board later.
Thank you.
Thanks, Nick. Linda?
Since Alan suggested that boards contact their state senators, do we want to do just that? Is that something that?
Well, we have done that.
Well, but they said do it again.
Yeah,
Do it
it doesn't
now.
hurt
Do
to
it
do
now.
it again, and in fact, the email that I was gonna send around from Alan has the link so that each of us can talk to our own state senator, state reps, as we have before, but it wouldn't hurt to reconfirm. I know I've talked with Paul Voino several times. I'll be happy to make a call again. I believe Wozniak has committed. I don't know if we've heard back from Senator McDonald one way or the other.
Do we need a motion to do that as a board? In time for
We
next
could
week?
do it individually, and just on that note, the Board of Commissioners tomorrow is bringing up the resolution in opposition to those, so it's almost timely because that would go out either probably Friday or early next week. So there's some more reinforcement there, and we have been getting, I know I work for a state rep on the other side of the hallway, but we are starting to get the emails trickling in from advocates opposing those bills. I have not seen anything in support yet, but I'm sure if it gets through the Senate, we'll start to get hammered
It
one
wouldn't
way or the
hurt
other.
to resend, David, what we've been sending, or what we've sent before, just, because it'll be right on time, at least to the three senators, because they're the one, it's most timely that way. They got something a month ago, don't
Just a
think-
reminder, gentle nudge.
I'll do that tomorrow.
Thanks, Dave. Thanks, Nick. Linda, did you have anything else?
No, just my question to Nick, I guess, is did we do something as a board or just?
We had a
individual?
whole program.
No, I know,
We sent
but
them. I'm trying to remember, I'm sure we passed a specific resolution as well, did we not?
Okay.
I'm trying to remember now. I mean, we basically met with them and sent them a whole tape and did a whole program, and so I don't
right,
remember if we
at
did a
our
specific.
breakfast, but.
Yeah, it was,
but what could
and we sent that
replicate?
around again, a couple of different times. I don't remember if there was a resolution
We
as
didn't-
such, or there was.
This body didn't do a resolution, but the Board of Commissioners did instead,
I know the Board of
based
Commissioners.
on our recommendation, our strong recommendations to do one.
Yeah.
And it was a good thing.
Tomorrow we'll see. Still have 24 hours to go. Anyone else on this topic before Dave jumps to the other 8 things he has? I can see his notepad. All right, Dave, go ahead.
I wanted to thank Christina from Network Operations and her team. We had a very nice jail diversion bidders meeting for that RFP that we did issue out. So the responses are due next month sometime, and we'll bring that information forward to the board. As a reminder, the MCHE annual meeting is March the 3rd, which is next Thursday. I chair that group, and I represent this body on that board. Connected to that, the MCHE is the MCG contract.
Okay, Dave, what's MCG and what's MCG?
I can't tell you, that's top secret. It's since the VP's, yeah. The,
On our list of acronyms.
Yeah.
if you can't dazzle them with brilliance. So, MCHE is the Michigan Consortium of Healthcare Excellence. It is 9 of the 10 PIHPs. And basically, it's the PIHP group. And we work on reciprocity and reciprocity. So the training stuff, the the monitoring things that are responsible at the PHP contract, we do through that group. MCG is the parity. So Michigan passed some laws, standards, rules, policy that we had to have parity. So we have to have a standardized mechanism for looking at basically how we're reviewing and authorizing some of our services. Primarily it's used on the inpatient hospital side. So MCG is the company that provides that, and it gets loaded up, and our MCO staff, our managed care operations, use the MCG modules to, when they're doing a utilization review. When the MCG contract came out, the Macomb, this predates me, decided they didn't want to be party to the group contract that goes through the MCHE board. Those issues have been resolved at this time, and I think it's definitely behooves Macomb to be party to the larger contract. That way we keep pace with the rollout, with the whole contract negotiation process and everything else. We're doing it as the group. So that contract is coming, will be coming in front of the board. I will be signing the MCHE contract with that board's approval, and both of those are kind of coming up at the same time. So there's a Macomb portion of the contract. The format's changed now. It'll be under the whole group contract for MCHE with Macomb's signature. So I wanted to give you a heads up that you'll be seeing that formal contract. It's currently going through the legal review process I described earlier, and that'll be coming back here to the board. The annual meeting is next Thursday. You all are invited. It's pretty quick and simple, but we will also be probably mentioning MCG at that board meeting next Thursday. If you're interested, I will be sharing, I'll probably get an update out by Friday of this week to that board, as well as to our board, about the agenda, the exact time, the login information, all of that. Also,
Is that the 3rd?
Yes. Yeah, Thursday the 3rd. It'll be 11 or 12, right in that range. Our CCBHC expansion, our goal was to serve 3,000 people in our first 2 years. We got about a 4-month ramp-up period, so it was less than 2 years. It ends in April. We are currently at 94% of our goal, or 2,827 people. So we are doing very well on that one. And as a reminder, we are ending our expansion grant and focusing on the demonstration. Richard and I had a conversation with John Villacerta, who's the point at the state, just to help clarify some of the unique situations, because Macomb is a PIHP, a CMHSP, and a CCBHC demonstration. And then we have expansion grants working within our county, providers who have the expansion grant working within our county. So it gets complicated real quick. The state's working out a lot of this as they go, but overall the relationship is good, and we are very much in support of the demonstration project. We will be transitioning those 3,000 folks from the expansion grant to the demonstration. Those activities are currently underway, so those folks should not see any change at all in their the services and the care coordination that they've been receiving. Thank you. As we were talking about the non-hospital, non-residential rates, it sparked another reminder. The My Health Link folks are the people with Medicare and Medicaid. We are responsible when they get hospitalized. The Medicare rates are obviously typically always higher than the Medicaid rates. I'm learning there used to be a pricer that was set by the federal government, by CMS, that would adjust the Medicare inpatient rate on a number of factors. CMS stopped doing that. So we did not have a way to adjust, calculate the Medicare rates for the My Health Link people who were in the hospital. We waited to kind of see what was going to happen, and the federal government has not done anything. So we are working to get the hospitals current on that, and we'll be bringing forth to the board a rate adjustment for the My Health Link hospital per diems, and it's our best guess. It's kind of the middle of the road from the Medicare rates, and so we'll be bringing forth in March. You'll see another hospital per diem increase that's higher than the one we currently have because we're trying to match the Medicare rates, but it's specific to the My Health Link folks who do have Medicare and Medicaid under that separate funding stream. So heads up for that one. We also we'll be bringing forward a rate adjustment specific to the DCOs under the Ccbhc. And I just said that just for the DCOs are our designated collaborating organizations underneath the Ccbhc demonstration project. There are some additional requirements and billing issues specific to that group. So we will be bringing forward a recommended rate differential for our providers who are operating as designated collaborating organizations. So expect that next month as well. So I'm giving you like previews now. That one. And I made a note about Tracy. Richard made a comment about our general ledger. The report you have is our first from there. We did also implement a new HR payroll system called UKG. So I will be asking Tracy Smith to give an update to the board about how that implementation is going. I'm sure she'll be thrilled to do that. And I'm putting her on the carpet in an open meeting, so that's always fun. And that's all I have. I will get those emails from Alan Bolter out to the board, and I'm happy to answer any questions.
I've got Nick and then Megan.
Well, first I want to thank Megan for reminding you about acronyms. We used to have a fine for using acronyms as a policy of this board a while back, and since we don't, if we had
like a swear jar, you get.
Yeah, exactly.
We can donate it at the end of the month.
Yeah, the CMH PAC would be very appreciative of your contribution at this point. On the My Health Link issue, these are people who are qualified for both Medicare and Medicaid. They're dual eligibles. I'm kind of confused why Medicare isn't covering the hospitalization.
It is covering it, but it's through us.
So they send us the money and we send.
We
and
pay
then
the
we
hospitals.
pay rather than them paying the hospital, because Medicare is a purely federal program, and usually that's not how it works. Okay, I see.
Yeah, we are the funder under that program. So for us to pay our regular Medicaid hospital rates, the contracted hospitals under that program are like, hey, wait a minute, we get this much
The
for
Medicare rate.
Medicare.
Yeah, I understand that. I'm just, okay, thank you.
Yep.
Thanks, Nick. Megan?
Yes, so for the
DCOs.
thing, or no, I'm sorry, not the DCO, for the UKG is the payroll thing, I'm sorry. and I guess for Richard, so with that new payroll software and with the new budget acronym, something that's an acronym, the new software, I know Richard said that there's some, bugs with the new software, but I actually did want to know if that whole switch, that October switch of like now you pay it by the fee for, so I don't know the good things to say. I listen, I swear, I know what I'm
The
talking about.
October was
Yes.
the general ledger
The
implementation.
general ledger implementation, is it, do you actually like this though? Like, is it, I know it's new, and I know it was gonna be different from the way that we've always done it, but is it bad, or is it just different?
I'll let Richard speak to the general
Richard's
ledger,
smiling,
and
so
then,
I feel,
and to be clear now, the payroll HR system,
yes.
we pushed back, and that was in January.
And that's,
So-
and the way that we, Richard, I'm gonna say it helps me understand it if I give a little mini synopsis first. But the way that we used to bill and the way that we have to bill now, our software could not do that. So that's why we got this new, I'm saying bill, maybe that's not the right word.
Track,
Our software
report
cannot
cost.
track it correctly. So again, I know it's new, I totally get the new software thing, but is it bad or is it just different?
Different.
Okay. Is that like wink different or is it like,
So I usually, I mean, and this is some of the feedback we're giving to staff as well, right? Let's try to give it a full fiscal year, like a full cycle, right? Because there's always going to be those situations where, you have that one-off where the system doesn't, we planned 95%, right? And that's that 5% that we're going to bump into. So the primary purpose of the switchover, which was to be able to track by the new state standard cost allocation rules, that appears to be working. The number one piece of that was the payroll, which was going live on January 1st. And I do know that there are more bumps on the payroll side because it does require a lot of human interaction, right? Every staff is touching the payroll system. So there's a lot of training involved. We don't expect the data to be perfect, right off the bat. So we're going to be evaluating it and verifying that it's working correctly. And we've had this conversation with the state of Michigan, and they recognize this first year is going to be a learning period. But when I look forward in terms of where we're headed and when we're going to get there, I think we're going to get to the summertime and we're going to look back and say it was worth every moment of time. So I think it's going to be worth it. Mm-hmm.
thank you.
Yep, absolutely.
Thanks, Megan. Anyone else with questions for Dave on his report? Comments? No? All right. We will move on to item 11C, the QAPIP, and since I don't want to pay any money, the Quality Assessment Performance Improvement Program. Thanks, Google. And before Stacy gets started, I need a motion to receive and file her presentation.
Support.
Motion from Megan, support from Linda. Sandy, I think, are you ready to switch over?
Are you gonna do the?
No, never mind.
We had
Stacy,
a vote
go ahead.
Before you came in, given the size of the documents, and actually Lori and Sandy and I kind of voted. There's actually 4 documents that I provided you. The very first one is actually 55 pages, so I wasn't going to slide it all for you to kind of save the day. I'm going to touch base on the historical documents. So I went down a rabbit hole to learn about the Quality Assessment Process Improvement Plan. Last year was the first year that
It is on, all her documents are on here, on the iPad for you. to look at.
Yes, sorry. And just historically, so you had to submit a quality assessment process and improvement plan to the department, but the technical requirement for it was 2 pages, just said, have a little plan. And last year, they decided to audit these programs. And this was the first time they've audited. And they audited them based upon feedback from the Health Services Advisory Group, so HSAG, who does our external quality review. Through Stop. I'm not paying. I'm going to say all the words. And essentially, oh wait, that's right, under AP rules, after I've said the whole word, HSAG basically went to everybody and said, wow, these are not really quality assessment process improvement plans. So the quality folks around the state said, what is one? So we all really did go down a rabbit hole. I went to actually every prepaid inpatient health plans program and community mental health services programs, and I pulled them. I'm looking. And the first one I found was 400 pages. And I'm like, oh gosh, my board's not going to appreciate that whatsoever, nor is anybody who has to implement it. So I found one I kind of liked. And in order to, we're required to submit it to the state. It has to be approved by our board. But what I found out a week and a half ago was you also have to submit the evaluation from the program from the year before. So luckily, Cindy had pulled some things together as she went along. Now, the process that Macomb had implemented was that to write the quality assessment process improvement program, they'd go to each director in each department and say, please tell me 2 goals for your department. And those will be what we will decide to work on or to gauge or to measure. And so the departments would say, I think we're going to work on this year. Well, the state said, okay, but what about those other things, those performance indicators, those key performance indicators that I've referenced? We did have what was submitted in 2019 called the Process Improvement Plan. Now that's a much more rigorous review that is done. And ours was submitted and it was not validated when it was reviewed this past summer by the state because, well, for 2 reasons. We actually didn't meet it. It was about recidivism. It was to make sure that our recidivism dropped and instead it increased. Now, we had COVID in the middle of that, so that was a big part of it. We had all kinds of things going on. So the process improvement plan is supposed to be one particular area that your agency is going to work on over a 2-year period, and it's written like your master's thesis. It's a much more detailed thing. That part is coming. So you have 2 historical documents. The first one, the really big, thick one, is called your Macomb County Quality Improvement Annual Work Plan Review Summary. And that was the one in which it was reviewed how basically we did. There were 15 goals that quality had set forth based upon those things I talked about that every department said, we're going to work on this year. And there were, as an add-on, the goals for the Certified Community Behavioral Health Clinic. So the CCBHC program had their own goals. They have a guidebook. It's a pretty great guidebook telling them all the things that we're supposed to be measuring. Those were add-on goals. So this 55-page document details basically how they did on those goals. So I'm going to put that one aside because that was last year. The next document was the Quality Assessment Program the Quality Assessment Performance Improvement Program. This again is a historical document that's 18 pages. It's just a narrative summary about these 55 pages. This is how the state asks you to do it, so that's how it's done. But it essentially goes through those goals that were identified, how we may not have met those goals, and it's the narrative summary. So the fun part is what we're going to do this year. And it's a little different, it's a little shorter, since you know, took me up to the last couple of minutes. But when I got to talking with Dave and Adam about the key performance indicators are a big thing. And we have had myriad of issues with those. A lot of them, for example, the state will all of a sudden give you a huge code change. January, big code change, and all of a sudden those key performance indicators where you might have had situations where you had 50 cases that we had to go back and manually adjudicate. As of this morning, we have 1,536 because there was a code change. So we'll have to look at all those cases that are outliers and find out, was it only because the right code wasn't used? So there's lots of things that come into play there, but again, this is information that's submitted to the state. This is also information, as Dave so boldly pointed out on Friday by sending it to all the staff, we will get a report called a consultation draft that compares everybody. So there's a CMHSP consultation draft and a PIHP consultation draft that will compare you to the whole rest of the state. So everybody gets to see it on these 20 pages, how well we're doing. In the PIHP report, it will give you a statewide total percentage, and then it will list all the PIHPs. So you want to be that one that's like, oh, I don't want to be the lowest one. Hey, wait, if the state's at this, I want to be higher type of thing. So sometimes there's some glaring numbers in there. They do the same thing for community mental health services programs. So when I looked at the Quality Assessment Process Improvement Plan, your actual QAPIP, it's a short document. I won't lie to you, but it's a 9-page document that says, okay, this is what our program is. We have a very small department at the moment, but we have a quality council, and the quality council exists of a director and a chief from every department. We've also added Megan as our board member at large to this committee, where we will be seeking guidance, input, and direction from all of these folks as we move forward. It used to be that we would ask them to report back to quality. We'd say, how are you doing on your goal in this area? And that would be how we measured how they were doing. This will be much more data-based. A big focus of our strategic planning last year was to become a data-based agency. We have lots of numbers out there. We have lots of data. We want to see things that will help us use those numbers to support the things that we're doing. So your 9-page quality assessment process, quality assessment and performance improvement plan just simply talks about the change and the fluctuation that we've added a board member that we will review at a minimum on a quarterly basis and be developing much more data-based information for the quality assessment process improvement plan. And the more fun part is what we're actually, your 5 pages called your quality assessment annual work plan for fiscal year 22. I've set 4 goals. 4. And the reason I did that, we looked at our strategic planning. As Dave has talked about, we meet on Mondays. Every Monday for leadership. We have rocks. We have these separate 90-day projects. They all build towards specific things. But it's easy to say that based on our mission, our strategic goals should be enhanced quality of service and effectiveness through improved consumer experiences. That's a great one. I wanted that one to be first. I think that's very important, the feedback that we get from the people we serve. And while this was on our radar last year and it was listed, the improvements they've made were huge. We have a customer service agency. We have a front-facing 1-800 number. They've actually set up that their 90% of their calls will be answered within 30 seconds. How many times have you called a 1-800 number and gotten that? Chanel has put together some amazing materials, including scripts, including guidance for all the staff that are in our customer services unit. I know I've mystery shopped it myself just for fun because I'm so pleased at how well they respond. We want to keep building on that. We do have satisfaction surveys. The prior gauge was we wanted to increase the number of satisfaction surveys we got back. Because you know when you mail something out, they may not come back. Well, we increased them huge. I believe we got 1,500 surveys back last year. But then we, in terms of taking that information and utilizing it to assure improvements in service delivery, the only time that we actually did anything with the data was if somebody indicated we want someone to call us back so we can talk about it, then those have been referred to ANWR for calling people back. So we want to make it a more personalized and personable experience. We've also talked about other ways to get information. We have those happy or not buttons. Have you seen them in our buildings? So that was really cool. I remember when we rolled that out at the beginning of COVID, and so I get these alerts all day long. You've got a happy or not situation. And the first 25 times I'm going, oh my gosh. Well, at Children's, I'm like, why are no, we had kids standing there just smacking the button, but we learned a lot, okay? But then we added it to our emails. There was a small glitch on there, but I do get to see that there's feedback that, you know, if I email Dave, there's a happy or not thing, and if I didn't feel that he was engaging in a core value of being, I can say that, and we get to push those buttons. But it's allowing, well,
I'll give you $1 for.
I'm really excited to hear this.
but the thing is, that information is available. It does have some bugs in it. I remember going through, we actually did Happy or Not awards this year. When we did our networking event, we actually had a Happy or Not award. Kathleen had one created, and the group that was able to get people to essentially actively engage in the Happy or Not more often got an award, and that was Clubhouse, was it not? It was Clubhouse, which was kind of cool. And not all your feedback is going to be good or happy. And because there isn't much room for the text piece, sometimes you're left guessing. Probably the one I receive most often, it will say mccmh.net, not easy to access, but it's talking about our website. But it's not, it's because if they hit the one under my email, it might give them the same thing. So we have bugs, but at least at a minimum, we have a data point. Currently, one of the things that we started a ROC about person served satisfaction and what are other places we hear about it. Here, sometimes, we have folks come and talk about it. And WAR takes in grievances. I wouldn't consider a local appeal an expression of dissatisfaction unless we made the wrong decision. But what other places? And it was pointed out very candidly to us that people that leave our services, people that don't come back. Also, though, people that ask for a change in provider. So what are some of the reasons for that? So I'm running that small group, and we're... Okay, you scared me. I kind of thought I was having an issue. That's okay. But we talked about how to gather that information in a much more impactful way so that we can track and trend it. If we're seeing that people are often asking to switch providers because they're not getting contacts back, because of they make them come into the office, those sorts of things, we can look at those for systems improvement. But what we really want to see is being able to create a dashboard so that we can show the community what people, the feedback that we're getting relative to service delivery. The other thing we never have asked for is if a provider's doing a great job. We don't give them an access for that. We don't give them, same thing for our staff. If you identify, we did staff nominations this year, but that was an internal thing. If you have a staff that's really exemplifying the core values, but if you have a provider who's going above and beyond, the customer service rule is that if you're cheesed off about something, you're going to tell 10 people. If you're happy, you'll tell one. So that restaurant that you got a bad meal at, you're going to tell everybody. But if you got a great meal, you might tell your best friend. So we want to give opportunities to provide positive feedback to our providers as well, and I think that's very important in this time. They are struggling. The folks we serve are struggling, and our staff are struggling mightily with the daily demands. So that's our, when we talk about the quality of services and the effectiveness. The next one was to improve health by increasing the provision of integrated care. Makes a whole lot of sense to me. If we are starting a certified community behavioral health, they're already tracking these things. These are already in data, but if we're serving somebody who has a pre-existing health condition, such as those that they're tracking for certified community behavioral health clinics, that if we're serving them for a substance use disorder, a serious mental illness, serious emotional disturbance, or that they're intellectually and developmentally disabled, that we're identifying that in their plans of service. So in the event that one of these qualifying health conditions is identified, that there's an integrated health goal, but a real integrated health goal, not just that I'm going to send a care coordination agreement, that even if you're just talking, discussing, that type of thing. Got this idea from Dr. Ward's group, worked very collaboratively with Ann and Sabrina, but that one made a whole lot of sense. So that was the adding of the provision of the integrated care goals. The other one that they had, and I was surprised that we didn't have it in other places, was to ensure all persons receiving antipsychotic medications are assessed for tardive dyskinesia at appropriate intervals. We're not tracking that anywhere on any side other than for the certified community behavioral health clinics. Really important, easy one. And when we were going through our NCQA review, they talked about our HEDIS measures and that we really need to start pulling some of this stuff in, those measures that we have. So the third goal is all going to relate to those key performance indicators. That is what it is, but the key performance indicators, we meet some. There's some that we excel on. Something I'll tell you, in the SUD community, when you talk about follow-up after hospitalization, they're 100% every time. We know that there's some tie-in, though, to my fourth goal, one about service provision within 14 days. Also, follow-up after a biopsychosocial. Follow-up after hospitalization within 7 days, and recidivism are all things that tie in together, and we think some of that goes to adequacy and capacity within our providers. So the key performance indicators will be a big piece of tracking. There's a young person that we hired in quality recently who used to do this for the Department of Health and Human Services on the other side, and she is digging in. And at this point in time, we are taking our data, instead of doing it a month and a half after, on a weekly basis now, we're starting to tell these providers, hey, you're out of compliance. Please look at these lines of data. Is this just an error on your part, or are you truly out of compliance? We're starting this formally by piloting it with the Easter Seals. I'm working very closely with Thomas Cole, our new Chief Information Officer, and Rachel, our Chief of Clinical Informatics, to kind of go, let's try it with one company. Let's see how it goes there, and then start putting out dashboards for providers. And then our last is to effectively manage the network. We've got a lot of providers. We've brought in a group. You've approved our HMA assessment to be done. It's not just a thing about a needs assessment, though. It's a capacity assessment as well. I can have a gazillion providers, but if they don't have capacity to serve folks, a lot of this, again, will be data-driven based upon utilizations and intakes. Having some great exchanges with Christine Brothers, our interim director of managed care operations, about numbers. Well, how many average folks do you get in a week in each one of our service category populations? If you know you have this many people, then we need to have this many providers. We need to have this many open slots. If you have this many authorizations for this service, we need to, at a minimum, have this many units available within our provider network. So they're lofty goals. You will hear about them quite a bit, because I'll have to get other things approved from you moving forward. I'm excited about them. And do you have any questions?
Thanks, Stacy.
Okay.
Dave has a question.
It's not a question, it's a comment. I just wanted to thank Stacy. As you can tell by the volume and the detail of these documents, she has done a real heavy lift to get us on a really good path forward. So thank you very much, Stacy.
Thank you for the support. Hi. It's going to be fun, you guys. It's going to be different, but it's going to be fun.
Stacy, before you run away, Ryan, go ahead.
I don't have a question. I just have a comment. I just thank you for the presentation, and also that goal on improved experience and being data-driven and having these things measurable. I know you've been doing it, and Adam put together I don't know if it was Adam or not, but he talked the phone calls, and we don't want anybody waiting on hold, and we want our services to be as accessible as possible. So thank you. I'm glad we're improving the website too. So all good stuff.
Absolutely. I can't say enough about the customer services unit. If any of you haven't met the folks at customer services, they are doing an amazing bang-up job, have great questions, and every time that we'll talk to them about something, we had something come up about interpreters the other day, immediately there is a follow-up, a response, a script for folks to follow. And I'm not hearing about people calling there and not getting a response, and they are kind and friendly, and they even check me. They'll, Stacy, did you get that voicemail I left? Because it's great. It is a great thing to see from a customer services unit, so I'm really pleased. Yeah.
Thanks, Ryan. Anyone else? Nope. Thank you, Stacy. Thank you so much. All right, we have a motion and support to receive and file the presentation. All in favor signify by saying aye. Aye. All opposed? It is received and filed. Next is other possible agenda items. 2 quick reminders. We have program and budget Wednesday, March 9th here at 6 p.m. and then full board for March is the 23rd here at 6 p.m. Ryan?
Phil, just I don't think it requires a motion, but with everything that's going on in Ukraine right now, you might not know, my wife spent a few years during the war 20 years ago in Yugoslavia and still has some trauma over that. And I can only imagine, she came to me this morning, the people here, either they may have family members. And so just as we had some outreach with Oxford, and I know we're doing things from Afghanistan. I asked Dave, and of course I hope that the board approves, to work with Kathleen to investigate some targeted outreach to members of the Ukrainian community to let them know that they're not alone. We have services available. So that's all. And if you can.
Thanks,
That's it.
Ryan. I don't think we need a motion or anything like that. I think we can just. Yeah, see, it's already in progress. But thank you for mentioning that, Ryan. We do have a fairly large Ukrainian population, especially specifically in the Warren area. So thank you for mentioning that. Donna?
I just wanted to congratulate Linda, Selena, and what's her name? I'm tired. I haven't been sleeping. Yeah, LP next door. Lori, I attended the CMHA meeting a couple days ago, and they're running for offices. And I don't know really how it works. I'm sure Dave or someone else can explain it to us. But I just think it's wonderful that we have people on our board that stepped up and decided to run for those offices. And, I fully support that, and I think it was really, a big step for them to step forward and run for those offices. And I want to congratulate them for stepping forward because, it's scary to run for office because you might lose, but I think it was really honorable for them to step forward, and I congratulate all of them. And I'll support them in any way, and I know our board will. So I think it's wonderful for them to do it. Thank you.
Thanks, Donna. Congratulations. It's not scary to run for office, is it, Nick? Antoinette? Piece of cake, no problem.
You'll be doing some targeted outreach for people who run for office to provide support.
Well, thank you all for running. Anybody else with any other items? Nope. All right. We will move on to hearing of the public.
Good evening, everybody. My name is Sean. I'm with CEO, just to give the monthly report. For all of our buildings, they all hosted a Valentine's Day party. And at our Anchorville location, they served a free lunch. They also attended the movies and bowling. At our Clinton Township location, they had virtual sport activities in their rec room. At our Mount Clemens location, they had a staff retire after 19 years of service to the person served. At Washington, they made over $140 for their Valentine's Day fundraiser. They helped deliver over 175 Meals on Wheels, and also currently working on finalizing details for the breakfast with the Easter Bunny. For all of our locations, CO received a donation of supplies from Party City and helped aid in the interior decorating of libraries across the company. CO had volunteers participate in community service for a local homecoming of 110 airmen that returned from deployment at Selfridge. Further volunteering will be later completed in July during the open house / air show. And then finally, CEO is planning and preparing for spring activities and upgrades around the buildings so that we can spend more time outside, enjoy all the property we have, as well as more exciting plans to come with the warm weather and such as utilizing more parks and such. And thank you and have a good night. And then as well, from myself and also from all my other staff and everything, we appreciate the 8.62% as well. So thank you very much.
Thanks, Sean.
Have a good night.
Thank you. You too. All right, one last thing. If you are up for reappointment and want to be reappointed, get your applications in. I think you have one more week. Wink, wink, nudge, nudge. Get it done. All right, with that, take a motion to adjourn. All right, all in favor? Awesome, we are adjourned. Good night, everyone.